Hi, well, we're just waiting for one or two more people to join, and then we'll get going in a moment. All right, good afternoon, and very welcome to this month's academic meeting brought to you by Global Surgery and our partners. We are very, very glad to see all of you here. And I must say, I'm looking forward to today's topic in particular. We have two excellent speakers in Peace Francis and Prof. Abebe. And I think they're going to be sharing some excellent things with us about surgical training in Africa. And they've got two very unique perspectives, or very different perspectives, and I look forward to hearing what they've got to say. The way we're going to run today is we'll start with Peace. I'll introduce her first, and then we'll hand over to Prof. Abebe shortly thereafter. All right, so over to the introductions of our first speaker, Dr. Peace Francis. She is probably well known to most of you here. She's a UCT alumni graduating in 2020 with the MBCHB. During her undergraduate time, she held various leadership positions, including the position of President of the Health Science Students' Council and Vice President of Talker Health. She was a recipient of the Klaus-Jürgen Barth Leadership Scholarship and was the inaugural winner of the UCT's Bongani Mayosi Medical Students Academic Prize. She completed her medical internship at Chris Barney Baragwanath Hospital, and no mean feat, and is a UCT Global Surgery MSc Fellow. Her research interests includes expanding access into global surgery for junior and aspiring doctors and increased African representation in global surgery. I'm going to ask you all to before I hand over to Pete, just to keep your questions for her and for Prof. Abebe to the end, and we'll have a 10-minute session at the end where we can discuss. Peace, over to you.
Thank you so much, Simon. Good afternoon, everyone. I'm just going to share my slides and then I'll get going.
Peace, before you go ahead, my
Sure.
apologies. I just wanted to, I see Prof. Abebe has joined us. Prof, just wanted to welcome you in particular to this call. It's very, very great that you made the time to be here. I'll do a formal introduction of you as soon as Peace has completed her talk, and then we'll move on to you. Thank you very much.
Thank you, Simon. I personally am very excited for Prof. Abebe's talk, so I won't be long, but I thought I'd just give an undergraduate perspective on our topic this afternoon, and then at the end just link it to some global surgery thinking. So I wanted to start off by speaking about training of physician surgeons in our continent. So when we think about how physicians are trained in our continent, what we see in most countries is the training of generalists or holistic clinicians. And this is usually what we see in medical schools. In most countries, medical school is an undergraduate training course. It ranges between 5 to 7 years based on the institution. And words like generalist and holistic are used to sort of speak to the broad exposure medical students and trainees get. The hope or the focus of most African countries is to train generalists who can work where the need is. Thereafter, most countries have a compulsory post-medical school internship or housemanship. The terminology differs. And in these countries, it is a 1 to 2 year program that is fairly standardized and includes rotation through or exposure to surgery. The exposure and rotation through obstetrics or anesthetics is country dependent. And then in some countries, after the compulsory internship/housemanship, we have further pre-postgraduate exposure, and this is usually a year of service. In South Africa, it's what we call our community service. In Nigeria, it forms part of the National Youth Service Corps. And here, the training or the exposure is less standardized, and exposure to surgery or anesthetics is not, does not always happen. So when we think about the providers of surgical care in our continent, or in the African continent, I've already spoken about the medical officer/general practitioner who has finished their internship or housemanship, their pre-postgraduate year of service, but that is just one component of our surgical care providers. On the extreme right of the screen, you'll see specialist surgeons and anesthetists, and this is usually a group we affair with people who have been exposed to postgraduate training, experience, plus minus research. But in the middle, we've got the non-physician clinicians who are also a key surgical care provider, especially in our continent. So what are non-physician clinicians? So NPCs are skills-focused healthcare workers. In most countries, they get an equivalent of a 3 to 4 year BSc or a 3 to 4 year BSc. And research shows that in over 50% of sub-Saharan African countries, NPCs are essential and part and parcel of the healthcare workforce. So NPCs perform minor surgical and anesthetic procedures, usually at a district hospital level. So they would perform uncomplicated spinals and GAs. They would perform cesarean sections, laparotomies for ectopic pregnancies, and in some settings, they would perform hernia repairs and even cesarean-related hysterectomies. So when we speak about NPCs, the conversation of task shifting comes up, and it's a highly debatable field, and I'm not here to open the can of worms or debate that, but I do want to share some pros and concerns. So in terms of the pros of task shifting and the use of NPCs in in a surgical space specifically, one of the key aspects that comes into place is the cost factor. So it is cheaper to train NPCs, and the personnel cost of NPCs are usually lower. People feel that it increases the surgical workforce in the sense that it increases the procedure rate. It decreases waiting times for minor procedures. And some people are of the view that it decreases the workload for physicians currently on the platform or in the systems. But task shifting is not without its concerns. So there's a question around the fact that a shift in priority or a focus on training NPCs can be detrimental to the focus of training specialists. And the truth is, and I'm sure that Prof. Abebe will go into this, but we are behind in our specialist density. We definitely need to be training more specialists in our continent. And there's a concern that there will be a shift and a deprioritization of training specialists. There are many concerns around the roles of NPCs. What are the guidelines in terms of training them, and the guidelines in terms of their practice? And there's concern that this isn't standardized and isn't well overseen in different countries. And then there's the question or the concern around the effects on referral pathways and referral quality. Most people would agree with me that no matter what the clinician's skill is, increasing the number of procedures will increase the number of patients who will end up in eventually end up in higher levels of care. Referral pathways aren't always clear in certain parts of our continent, and beyond that, referral hospitals and tertiary centers are not always well equipped to handle an increased burden of patients. So going back to this picture about who is providing surgical care, so you can see in this image, I've removed the specialists, anaesthetists, and surgeons. That's because research will show that most surgical care provided in our continent is provided by non-specialist clinicians, which being our medical officers or general practitioners and being our non-physician clinicians. And what is interesting about this group is that in most cases, these groups of providers are only exposed to undergraduate or formalized undergraduate health curricula. So what do these curriculums around the continents say about global surgery? So I spent some time reading through Health Council's curricula on undergraduate health education. And what comes up is that most of them mention primary healthcare and are focused or rooted or based on primary healthcare principles. They mention context-specific burden of diseases and a focus on training clinicians who are able to work in their context, who understand and are familiar with the specific diseases in that context. Some mention global health. They don't expound on it or necessarily define it, but it is mentioned in some curricula, and most curriculums speak to community engagement or focus on community health. But global surgery is not mentioned in curricula, but that doesn't mean it is not active at an undergraduate level in the continent. A lot of organizations, one specifically being Incision, have a large footprint in Africa and in the African continent, and are doing the work teaching undergraduate students and junior doctors about global surgery and exposing them to the principles of global surgery. So something I often say is that in some countries, in some continents, in some settings, global surgery thinking is an added extra, but I believe that for African clinicians, global surgery thinking is essential. And some of the reasons I say that is because global surgery is transferable. Whether our clinicians stay in the generalist sphere, whether they specialize in surgery, whether they specialize in medicine or something else, the skills and the thinking and the work of global surgery is something that will benefit them and be able to be transferable to different skills and different settings. Global surgery is multidisciplinary in its approach, and anyone who's worked in an African healthcare setting will understand that we need to be moving more and more into a multidisciplinary way of interacting and approaching healthcare. Global surgery's aims are core to health in Africa. And by the aims, I'm speaking to increased access. I'm speaking to quality healthcare and surgical provision. I'm speaking to treating a system and understanding a system and not just understanding the individual patient. And I do feel that these aims are important and need to be a focus if we're going to see positive changes in the African healthcare system. And then just tying back to point one is that global surgery strengthens the health system. Global surgery is not an island, but growth in global surgery ultimately results in growth and reinforcement in the healthcare system. So we've understood what the undergraduate pathway looks like for VISPA clinicians. We understand that most of our surgical providers in the continent are only exposed to formalized undergraduate training. We know that the curriculum doesn't emphasize or include global surgery, and we also understand the pros of global surgery exposure. So what can we do? So the first thing is to continue to make strides in postgraduate training and exposure to global surgery. And I know people like Prof. Masume, Prof. Abebe, and a couple of others on this continent are doing that. And the reason this is important is because inevitably undergraduate healthcare professionals are trained by postgraduate healthcare professionals. And so be it indirectly and in some cases directly, strides in postgraduate training and exposure will impact undergraduate training and exposure. We need to start having increased research and debate around task shifting. We need to address some of the concerns while also quantifying some of the benefits of it so we can make clear decisions. We can advocate for where government and training should be focused. Global surgery, should be integrated into the curriculum. And there's different ways of doing that, different ideas of doing that. I know that at UCT, it has now been integrated into the curriculum, but we should be advocating for more of that and also thinking broadly and laterally about how we can do that. And then continue to collaborate with extracurricular organizations. Organizations like Incision, I know at most universities there's a surgical society or group like that at an undergraduate level who are doing the work in places where it's not in the curriculum. And I think it's important that as clinicians, as students, as postgraduate students, we should be continuing to collaborate with these organizations. On that note, I want to just thank you. And I know that Prof. Abebe will continue to add color and a different perspective on this topic.
Peace, thank you very, very much. In an immensely short period of time, you've managed to touch on some crucial issues there, and I think laid a very nice platform looking at the perspectives of undergraduate training. So there are a couple of things I'd like to ask you, but I think I'll say that to the end. Prof. Abebe, again, very welcome. I'd like to just briefly hand over to Prof. Salami Mashime. She just wants to say a few words.
Greetings, everyone, and thank you. Welcome to our first academic meeting for the year, and thank you for the great attendance today. And just as you know, we have these academic meetings every Friday, but today we've got a really special guest, Prof. Abebe from the University of Rwanda. Simon will do a proper introduction shortly, but just wanted to say thank you, Prof, for joining us. Prof. Abebe is one of the global surgery leaders on the continent. He is running a global surgery research unit at the University of Global Health Equity. Is also the Dean and Deputy Vice Chancellor. So it's a real privilege to have you with us today. Also, thank you, Peace. Peace is one of our favorites who started with us as an undergrad and is currently completing her master's looking at undergrad global surgery training. So thank you for the excellent talk, and just welcome to all the new fellows, new PhDs, MSCs, and everyone who's joined us today. So thank you.
Thanks, Salami. Thanks for that. Without further ado, Prof. Abebe-Bekele is the Dean of the School of Medicine at the University of Global Health Equity in Rwanda, as Salami mentioned. He's a professor of surgery, so general and thoracic surgery, and has a full professor faculty positions at not only UGHE, but also at Addis Ababa University and the University of Rwanda. He has vast experience in medical and surgical education for more than 22 years and has served as a visiting professor and external examiner in undergraduate and postgraduate education in Ethiopia, across Africa, Europe, and North America. He's also the Secretary General of COSEXA and serves as Chairman of the Examinations and Credentials Committee for the past 7 years. Beyond that, he's published 100 articles and book chapters and is a recipient of several regional and international awards and recognitions. He also serves as a member of the Advisory Council to the Ethiopian Ministry of Science and Higher Education, very relevant to this talk. And Professor Abebe is actively engaged in global safe surgery and anesthesia initiatives and has served as a senior advisor to the Federal Ministry of Health, Ethiopia, in the Saving Lives Through Safe Surgery initiative. He is passionate about equitable access to surgical care, gender equity in global surgery and surgical education. And his research interests include trauma, surgical oncology, equity in global surgery, and education. His bio is, in fact, a lot more impressive than what I've shared with you there, and I'll try and share the full version of it in the chat. But Prof, welcome. Very good to have you here, and we look forward to your talk. Over to you. Prof, apologies, you're still muted.
Yes, my apologies. Thank you very much, Dr. Simon. Professor Masimwe, colleagues, thank you very much for the invitation. I really appreciate being with you today. And Dr. Peace, I think, gave a very good overview, a segue to what I wanted to talk about today. I don't think I need to introduce myself. Thank you for the generous introduction, Dr. Simon. I have nothing to disclose for this talk. Well, education and training of surgical practitioners is key, not only as just a form of training, but key for provision of access to care, anesthesia and surgery. And it's good to see that more than 80% of global surgery partnerships in Africa at the moment are mainly around surgical education and some form of training. Why do we need to talk about global surgery education and training? It's because in the world at the moment, about 1.1 million professionals are there, OBGYNs, anesthetists, and surgeons. However, 44% of the world population live in countries with a specialist workforce density of lower than 20 per 100,000. That means about half of the world population live in countries and in continents where care is not adequate, access is not adequate. And it is estimated that 2.2 million specialist providers are needed by 2030. That's discounting migration, death, and change in profession. You can clearly see that train should be the motto we need to be following. And 33% of the world population live in Africa, in the developing world, where only 12% of the surgical workforce exists. Therefore, this is a good testament to show that all of us in the continent need to focus on the training of surgeons, anesthetists, and OBGYNs. Again, to add salt to the wound, 24% of the global burden of diseases occur in the sub-Saharan Africa, about 25%. However, only 3% of the global workforce lives and practices here. So this, I think, is a very good context to decisions countries are taking, institutions are taking to further strengthen their undergrad, their postgrad, and fellowship level trainings. I tried to do a bit of a literature review, a bit of research around models of human resource for health development in surgical care in Africa, and 6 models clearly come out. The commonest are university-based residency-level trainings. These are programs started in the 1930s, mainly Nigeria, Uganda, Ethiopia, South Africa, and spread throughout the continent. The second are the college-based trainings, colleges such as COSEXA, West African College, and the College of Medicine of South Africa. At the beginning of the 1970s, countries started sending the cream of their society, their youth, to the developed world to get further training and come back and practice. It's kind of decreasing at the moment, but that was a model used by several other countries. And there are at least 2 countries in Africa at the moment that do not have their training of their own. Use of expat professionals, surgeons in different countries is still a model used in many countries. And Dr. Peace talked about task sharing and task shifting. I do not want to go to this discussion. This is very political and very controversial, so probably not something we need to just touch and go on. I would like to talk about 3 case studies, and particularly focus on the 3 models I talked about at the beginning, and use the University of Rwanda, the HRH model, what my institution is trying to contribute to Africa, and how and what COSEXA is doing to cater for the significant shortage of human resources. The first would be the Human Resource for Health program in Rwanda. This is a program that was initiated by the Republic of Rwanda, the Ministry of Health of Rwanda. As all of you know, Rwanda passed through a very difficult period in its existence in 1994. The 1994 genocide resulted in the complete annihilation of the entire healthcare system. That lingered on, the effect lingered on for more than 16 years. And hence the government decided something needs to be done to help the country recover from its loss. And hence designed a program called Human Resource for Health in Rwanda. Basically, it is a 7 years long program, quite expensive in its nature. In the first few years, it was covered by the US government through PEPFAR and CDC, and eventually at year 2, government of Rwanda took over, the Ministry of Health and UR took over the costs. It lasted for about 7 years, and more than 20 academic institutions from North America supported this program to train MDs, health managers, nurses, and dentists. Its goal is simple. Number 1, to train healthcare professionals, more professionals. And number 2, to strengthen the training departments, to gradually take over what the program started. It was projected that by 2019, when the program kind of dwindled down, the number of generalists and specialists would triple. And some specialty areas were selected to be focused on, including surgery and anesthesia. And it was also planned at the beginning, visiting faculty would be covering most of the training at the University of Rwanda. Eventually, as the number of trainees increased, as the number of specialists increased, as the number of Rwandans in the diaspora returning back to Rwanda, they will eventually start taking over the entire work by year 5, 6, and 7. And that actually the sustainability strategy that was designed. Since it started, it yielded in an extreme success. Lots and lots of trainees were enrolled, graduated. I'll talk about the numbers later, but a lot of hands-on exposure in the theater, a lot of simulation-based training. In fact, simulation was introduced to Rwanda during the HRH period. Now it's one of the strongest tools of teaching. That the graduates of the HRH program were evaluated, assessed through the American Board of Surgery's exam, and their performance was more than satisfactory, was remarkable. Hence, showing that university-based residency programs that have good partnerships deliver a lot to the training of surgeons and anesthetists. As you can see, every year, close to 100 faculty from the partner institutions were in Rwanda at one time or another, which gradually decreased down. And mainly it's around medicine and nursing midwifery. As the number of locally produced surgeons and anesthetists increased, the number of visiting faculty started going down. And these are the products. As you can see, from just 25 in the very first years of the program to more than 314, the cumulative graduates to about 314. A significantly impactful program in Rwanda. Hence, the conclusion we can draw here is that existing university-based residency programs need to be strengthened. graduating handful of surgeons and anesthetists is not sustainable vis-a-vis the pressing demands, the unprecedented occurrence of pandemics and catastrophes, the usual wars, the usual natural calamities we are facing with. Universities and countries need to step up in their efforts to train surgeons and anesthetists. The second, again in Rwanda, is by all mathematical modelings, by all projections, the number of surgeons and anesthetists to be trained in the coming 20 years will not reach the SAO density benchmark put in 2015. Hence, general practitioners in the form of task sharing carry a lot of responsibility in Africa. So through the School of Medicine at the University of Global Health Equity, where I serve as dean, this medical school program is 6.5 years in duration. By the time the students graduate, they will receive their MBBS or their MD and their Masters of Science in Global Health Delivery Master's Degree program. It's like MD and PhD program in the US. It started in 2019 with just 30 students. The plan is to increase by 6 every year. Hopefully this July, we will recruit 48 students from Rwanda, Burundi, Tanzania, Uganda, Sierra Leone, Malawi, Liberia, and Lesotho. And we recruit 2/3 women by policy. The School of Medicine follows a bit of a different approach to teaching. The curriculum is competency-based, which is vertically and horizontally integrated. By this, we mean social medicine, One Health, laboratory-based teaching, and integration between basic science and clinical sciences is completely effected. We try to shy away from traditional lectures, and we have successfully managed to do so. We depend a lot on flipped classrooms, team-based learning, case-based collaborative learning, and interactive lectures. Simulation has been integrated to the curriculum since year one, since basic sciences, and they visit the hospitals and the community from year one. This is not achievable alone. Africa has a lot of resources, but it's not yet there to be sustainable in its academic and research endeavors. So we depend a lot on partners to deliver this. Students are exposed to research from the early age, and I'm really glad to see the first 2 cohorts many of them are published by now. They are in year 3 and 4 at the moment. There is strong liberal arts and One Health integration across the years, and several of what we teach is emergency care focused. And this is a good segue to how we try to teach surgery and anesthesia in this university. There is clear evidence in Africa, the whole of Africa, that the role of general practitioners is huge. General practitioners do a majority of cesarean sections, quite a substantial amount of acute abdomen surgery, wound management and fracture manipulation, and a lot of basic life-saving procedures in Africa. More than 60% of CS in Rwanda is done by GPs. Hence, surgery cannot stand alone, exist without proper anesthesia support. Hence, the curriculum we designed for anesthesia, number one, is to expose and inspire the graduates to take up a career in anesthesia, and for them to have the basic knowledge, attitude, and skill applicable to working as a GP by the time they graduate. It's not to replace anesthetists on the job. It's not to convert them to critical care physicians, but to help them understand and do their jobs better. The job that was there since the past 60, 70 years. And hence we followed a Pan-African approach to curriculum development. Topics were derived from common tropical content in Sub-Saharan Africa and Rwanda. We identified priority surgical procedures. We recruited surgeons across Africa. I am confident there are members of our curriculum team in this meeting who supported us in the development of the curriculum. And we went through a modified Delphi process, 3 Delphi processes. And both the general surgery and anesthesia curricula were designed. The most important deliverable is we expect the general surgeons to contribute to anesthesia and surgical care by the time they graduate, even before they start residency. Let's train them better before that. And let's not expect them to learn on the job. That probably will not work. Hence, a hands-on practical teaching session was designed in anesthesia and in surgery, starts with a 1-week boot camp, and then hands-on exposure in the theater, accompanied by formative and summative assessment. These are the anesthesia procedures that we expect our undergrad students to kind of be exposed to. We don't expect them to be masters in it, but to be exposed. The second is we're trying also to prove that undergraduate teaching can be effectively delivered at the district hospital level, because this is where the patients are. This is where the cases are. Setting up medical schools in capital cities where patients are expected to travel or to be referred to. That means we probably are losing significant proportion of these patients because of lack of access to care. However, we understand there are advances in anesthesia and surgical care that the students need to be exposed to. Hence, they will spend significant amount of time in the capital city and abroad to do their electives and clinical attachments. UGHE has enjoyed so far a few international recognitions. We received the Aspire Award last year, and a few weeks ago we received the Power of Partnerships Award. So the conclusion from this is that even if we have to think about task sharing, let's share tasks with prepared people. Let's not let's not go through pathways where there is no return. And partnerships are key. The third model I want to talk about today are surgical colleges. I specifically want to focus on COSEXA. COSEXA was set up in 1999 by a few countries in Africa. It's an evolution of what we call the Association of Surgeons of East Africa. Data from COSEXA shows that the surgeon to patient population ratio is very difficult to describe. It's less than 1% for almost all the countries. And the average SAO density is 0.53 per 100,000. Not only that, the majority of the surgeons live in capital cities, major cities. Hence, we cannot talk about access in its all 4 forms in Africa. Hence, COSEXA is now constituted by 14 countries and 7 partner countries, countries we call satellite countries, those the countries you're seeing in yellow. COSEXA follows a college without walls approach. That is, we strongly believe existing hospitals and existing human resources can be used to train new patients, new healthcare providers. That's why 64% of our hospitals are outside of the capital cities. In fact, it has reached about 70% now. The same as what UGH is trying to do, we're trying also to prove that adequate surgical training can be conducted at the level of district hospitals, provided these hospitals are actually doing their job. At the moment, we have more than 150 hospitals across the 14 countries and 7 partner countries, about 900 trainees, and about 400 accredited trainers by COSEXA. And once a hospital gets its license, it stays valid for about 5 years. The model we follow is once candidates are enrolled, they do a 2 years basic membership program, they do a college-based examination and proceed to a fellowship-based exam training to 3 to 4 years, depending on which program they are in. For general and orthopedic surgeons, we also have a subspecialty fellowship program. And these are the training programs we have so far. The oldest are general surgery and orthopedics, and the youngest is cardiothoracic surgery that started about 4 years ago. And a lot of new subspecialty fellowship programs are also being designed. Hopefully in the coming 2 to 3 years, these programs will be launched. How we teach is, number one, the candidates keep a very strict electronic logbook. I checked yesterday, we have about 462,000 procedures registered in the COSEXA e-logbook. A lot of e-resources are developed and are ready to use by candidates. Module-based, LMS-based training at the MCS and the FCS level. We have a mobile surgical skills unit, a mobile skills lab that drives from center to center to deliver advanced skills-based teaching. The number of trainees in COSEXA has gradually increased over the past close to 22 years. We have reached a cumulative number of 2,358 at the moment, which is quite a number. And as of last year, December, total number of graduates is about 942. Our number of female trainees has also significantly increased. Between 2002 and 2010, there were only a handful of trainees, women, in COSEXA. Now, close to 30% of our trainees in COSEXA are women. Our graduates are progressively increasing. Last year, we graduated the highest ever number of surgeons for Africa, that's 128. And so far, we have contributed 758 surgeons across the several disciplines for the continent. And the female graduate number is also significantly increased. About 20% of our graduates are women. There are some countries who are benefiting a lot from COSEXA. Ethiopia, Kenya, Zimbabwe, Zambia are one of the few. The good thing about what's done in COSEXA is that a majority of our graduates are either retained in the region or in the country they are trained in. 93% of the graduates are retained in the COSEXA region. An Ethiopian may be in Rwanda, like myself. A Zambian might be in Zimbabwe. 73% of the graduates actually remained in the country they are trained in. Again, the main strength of COSEXA, in addition to the fact it's teaching in the district hospitals, it spans across 21 countries, it uses existing faculty and resources, is its partnerships. It works significantly with available partners who share the same vision, including CMSA. The partnerships mainly are about visiting faculty. Many visiting faculty visit this more than 130 hospitals. Our partners help us in writing MCQ questions and clinical cases. They actually show up during the exams to do the virtual OSCE and the in-person clinical exams. Several volunteer in our journal. They support in journal editing, peer reviewing. There are several who write educational programs with us and deliver educational programs with us, including the basic sciences modules. There are many who work with our trainees to support them in their research, funding, and in mentorship. And there are individual surgeons and institutions who provide scholarship for our students. One concept I need to mention here is the American College of Surgeons and Association of Women Surgeons in America. They provide scholarship for 20 women to sit for the COSEXA exams per year, which has been the pillar behind the dramatic increase in the number of women trainees. So in conclusion, I would like to point out two things. Africa needs to have its own vision and goals. How many surgeons do we need? How many anesthetists do we need? Who should be, at what level should be the practitioners needed in the continent? It should be our decision. In fact, it should be the country's independent decision. If the country strongly believes task sharing is, or task shifting is the model they want to follow, I think they should be encouraged to do that. They should have their own vision and goals. However, copy-pastes will fail. Just because somebody else is doing it, we should not. And what's good for the goose is not always good for the gander. And as my former chancellor, the late Paul Farmer, said, with rare exceptions, all of our most important achievements in life come from partnerships. We should strengthen the partnerships we have. Thank you very much for your attention, and I'll be very happy to accept if there are any questions. Thank you.
Prof. Abebe, thank you very much. That was excellent. So I think it's given us all lots to think about. I particularly liked your take on saying that we need to, if we do task share with prepared people, and that we need to build on those partnerships. I've got a couple of questions, but I can see some hands. Ivan Zolo, do you want to kick off first, please?
Yes, thank you very much, Dr. Simon. Thank you very much to the presenters for the amazing presentation and the great time you just spent. My question is for Prof. Abebe. So I can see that one of the main challenges that in developing such programs and courses usually has to do with the provision of funds. And I would like to know, like, in your own experience, what has been your, how do you go about facing this challenge, and how do you go about like convincing funders to invest their money into your program? Thank you very much.
Thank you, Doctor. I think it's a very important question. I guess it all depends. It all goes down to the resources you have. The quality is probably strongly associated with the resources you have. In my experience, if we have good ideas that are generic, that are context-oriented, that can actually influence patient care and improve patient outcome, the funding is usually there. It's a question of expanding networks, talking to people who have the resources, the availability of the resources, and working with people, developing the partnerships. The funding is usually there. It's just that, unfortunately, I'd like to blame myself. Life in the theater is very secluded. We are very proud, and actually we should be for spending 10 hours a day in the theater, helping patients, alleviating suffering. Unfortunately, it comes at a cost. And that is why, as Peace earlier said, global surgery is key. Global surgery is mainly about partnerships. We need to dedicate some time to open our eyes and to start working with people. When this invitation was extended to me to speak today, I accepted in an hour, because this one opportunity to expand my contacts, my partnerships, to share what I have. And this is how funding comes. This is how people hear about the good ideas we have. People hear about the impact we will have soon, and that usually comes with partnerships, money, resources, faculty, and things like that. So I don't think you should be discouraged by what looks like an apparent lack of funding. I don't think you should be. It's usually out there.
Thank you very much.
Thank you. To the next question, I saw a hand by Ala Ibrahim Mohammed.
Hi, how are you doing? So thank you, Professor Abebe, and thank you, Dr. Peace. Actually, my research question is also regarding the task sharing for being personally an anesthesia technologist, working the full list of 20 to 30 emergencies per day and so on. So, and I'm also a faculty at the university. So when we teach our students, do we need to focus on a competence-based education, or like a community community education regarding taking the responsibility of all the patients coming, and do we need really to teach them that we face a huge number of surgical operations per year and that we need to cover and all kind of things. I don't know if my talk is organized, but I hope you got my point.
Yeah, thank you, Doctor. I think I captured the essence of the question. I think let's look at what we've been doing for the past 50, 60 years. We've been producing, myself included, technically competent surgeons, really fantastic technicians. You put any one of us in the theater, we can do miracles. However, look at where access is. Look at where the SAO density is. Did we even understand the concept of SAO before the 2015? Did we even understand what cost effectiveness meant? Did we know how much it is needed to establish a surgical system? Did we even understand what the 3D lays were? When we started broadening our view, looking at what's around us, in other words, looking at the community, the social medicine aspect of surgery, that's when we understood. We cannot win the global surgery war just by being excellent technicians. An excellent anesthesiologist saves one life, or 2 or 30 per day, as you put it. But that's just it. You cannot impact the population. And we are, at the end of the day, responsible for our people. Fortunately or unfortunately, we are the ones in this time at this time put in the position to lead the healthcare system, to teach, to provide care. So I strongly believe tomorrow's healthcare providers need to know their surrounding. We should not accept the fact that we have a waiting list for 1 year. We should understand why. We should not accept to say, oh, this number of my patients disappeared from follow-up or failed to come to surgery. Why? Do they even have transport to come back to us? Do they even have food for their kids? Do they have anyone to accompany them when they come to our theater for surgery? These are the social medicine pieces that we should understand. And I strongly believe tomorrow's professionals need to be competent surgeons, passionate surgeons who understand social medicine. I hope I have made some sense.
Yeah, you perfectly did. Thank you so much.
Thank you. Thank you.
Absolutely a challenge to really focus for all of us on the social medicine side of things and understand the context of our communities. Prof. Patrick, a guest here at ECT Global Surgery, but also currently in Zimbabwe. Your hand was raised.
Yes, thank you very much, Simon. I'd like to thank the speakers, Dr. Peace and my brother, Prof. Abebe, for a very good expose. I have a question or a couple of questions with some comments for Professor Abebe. First, I'm happy to see that the statistics for the HRH are very encouraging. Having been in the works of that, I am happy to see that it has carried on with the deliveries that we had anticipated. Now, looking at the training of surgeons, I have 2 questions. One, taking from the quotation that you gave us from our dear late friend Paul Farmer on partnerships. From your experience, what or who are the key stakeholders that we should be engaging beyond the surgical fraternity? Because we know it is a multidisciplinary task that requires several stakeholders. From your experience and from your current thinking and knowledge, who should be the stakeholders? We are looking at the development of NSOPs, for example, in the different countries, which demand a lot of input from several other sectors beyond health. What has been your experience? The second question that I have is from a systems point of view. When you go systems, I would like, and I normally tend to gravitate towards the McKinsey 7S framework, which looks at several aspects, strategies, systems, structures, and the like. What is the weakest link in there that we should be addressing to really strengthen the surgical training on the continent, and especially to meet our global surgical needs? Thank you very much.
Patrick, thank you very much for the question, and I'm so glad to hear your voice. For the members of this meeting, Professor Kaimano was the Dean of the University of Rwanda during the HRH program, so he should take credit for all the great work done for that period. And as you said, who are the key stakeholders in surgery? I think all of us. I think it should start from us, the surgeons, the gynecologists, the anesthesiologists. We first should recognize that we are indispensable in the surgical ecosystem. We should recognize if the cleaner is missing from the theater, surgery stops. We should recognize if the cashier at the chart room is missing, surgery stops. In other words, we should start from ourselves, in the hospital, in the country. Number two, regionally and intercontinentally. Professor Massimo has done, I think, a lecture or two for my medical students over the past year. It might seem simple, but it sends a huge message that we are together. The students understand she's there for them. We need to start working with one another. And then professionals of our sort, globally, surgical colleges, funders, and things like that. And then the community, in general, the community. These are the stakeholders. I strongly, strongly urge all of us to recognize each other, one another. This petty issues between us, surgeons and anesthetists and anesthesiologists, which does not take the patient welfare as a priority, but just us. It should never be about us. It should be about the patient. So I think partnership should start from us. And the stakeholders include, there is this beautiful cycle of partnerships that I sometimes talk about. Partnerships start from discussions and ends usually as capacity building, as monitoring and evaluation capacity building. If we follow that pathway, then partnerships become kind of simple. And so stakeholders include the community, the patients, the healthy people, the government, the professionals, the leaders, the funders. If we bring everybody together from day one, brainstorm about the importance of NSOPs, bring everybody together, move on. I think it can be done. Some countries have done it. Probably not the perfect way. There's a lot of lessons to be learned there. But doing it together, not giving the impression that it's being imposed by a third party. Or some groups should not feel they are guests, but they should own it. I think systems can work. The weakest link, as far as I'm concerned, in the surgical ecosystem are systems. We have exceptionally good surgeons, exceptionally good anesthesiologists, exceptionally good radiologists. Then why is quality eluding us? We have bright young men and women in high schools, in medical schools, in residency. And yet, what we have seen our residents 25, 20 years ago still repeats itself. Why is that? Mainly because of systems. So global surgery, as it should be, should focus on systems strengthening. At UGHE, the healthcare system, we use 4 S's.
Prof, apologies, we just lost you there at 4 S's. I think you were accidentally muted, or a few of us were accidentally muted. Would you mind repeating the 4 S's?
No worries. We talk about staff, human resources, staff, equipment and resources, systems, and space. In my opinion, it's the systems we are failing miserably at.
I feel like you're tempting us to invite you back for a talk on system strengthening, but we can negotiate about that later. I'm unfortunately aware that our time is running out, but I do want to give Prof. Salome a moment to ask a question or make a comment. Salome, over to you.
Cool, thank you so much. And it's just a comment and to just say thank you so much to both of you. I think such excellent talks and helping us think through so many things. But I think just to highlight a few points, I mean, I think both of you are highlighting that we need to rethink how surgery is taught at undergrad and postgrad level. The fact that, you know, it's not enough just to teach the surgical skills, systems and teaching about systems. And that's where that intersection comes between teaching surgery and teaching global surgery, because every surgeon should be taught a bit of global surgery. And clearly at undergrad level, in many of the spaces, not enough surgery is being taught for people that are going to do the majority of the surgeries in their countries. And then I also love the point, excellence isn't enough. Being an excellent surgeon isn't enough, because it doesn't determine the quality of care that you can offer. If you're excellent in a failing system, your outcomes are still going to be bad or compromised. So thank you so much to both of you. And yes, we will invite you again by popular demand. But thank you, and thank you to all of you who've joined us today.
Absolutely.
Thank you.
I can just echo that. I think it's been a massively interesting talk, and I think we could do a whole day on this topic. I think there are many people in the audience as well that I would have liked to have heard from more. I was just sending Salome a WhatsApp on the side saying we need to, while Prof. Patrick is around, get his inputs as well in one of these talks. Absolutely. But thank you for sharing that, both to you, Prof. Abebe, and Peace. I think we've got lots to learn. I really enjoy this idea of partnerships where we look at focusing on all those important partnerships within our theatre, from the cleaner to the surgeon and the nurses, to regional, local, and to community based. I think that's so important if we want to get things done, if we want to improve that system. So, Prof. Abebe, Peace, thank you so much. Thanks to all the delegates, and we look forward to catching up soon again.
Thank you very much. Thank you very much.
All right. Have a good weekend.
Bye.
Oh, well done.